You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about biomarkers and lab abnormalities in congestive heart failure. There are actually 5 structurally similar natriuretic peptide hormones: ANP, BNP, CNP, and DNP. Atrial NP, or atrial natriuretic peptide ANP, is released by atrial myocytes in response to acute increases to atrial pressure, so it functions similarly to BNP. Urodilantin is an isoform of ANP. BNP, or brain-type ANP, is released in response to hemodynamic stress from ventricular dilation, hypertrophy, or increased wall tension. C-type NP is derived from endothelial cells in the peripheral vasculature. DNP is dendroapsis natriuretic peptide. The roles of urodilantin, which is an isoform of ANP, CNP, and DNP in cardiovascular physiology remain unclear, and you don't need to know about these ones for the board exam. For ANP and BNP, both of these are elevated in heart failure, and both promote vasodilation and natriuresis, counteracting the salt and water retaining effects of the adrenergic renin-angiotensin-aldosterone and vasopressin systems. Prohormone BNP is cleaved by circulating endoprotease into 2 polypeptides, the inactive N-terminal proBNP, which is 76 amino acids in length, and the biologically active peptide BNP, which is 32 amino acids in length. BNP increases glomerular filtration, GFR, urinary sodium excretion, UNAV, and thus urinary volume, which is what we want, i.e. diuresis and natriuresis, when someone is volume overloaded. BNP suppresses the RAS system by inhibiting renin secretion via natriuretic peptide receptor A, NPRA, in order to reduce plasma volume. It also reduces adrenal aldosterone secretion. It causes peripheral vasodilation and increase in vessel permeability to offset the intravascular volume, thus resulting in elevated hematocrit. BNP inhibits cardiac hypertrophy and fibrosis. Outside the cardiovascular and renal system, BNP stimulates lipolysis, increases insulin secretion, and reduces sympathetic nerve activity. BNP is subsequently degraded by neprilysin from the kidney into less biologically active BNP products. 25% of BNP is passively excreted, unmodified by the kidneys. The rest of BNP is eliminated by binding to the NPRC receptor or through enzymatic degradation by neprilysin. Conversely, NTproBNP is only passively excreted by the kidney, which is why NTproBNP has a longer half-life of 120 minutes compared to 60 minutes and higher plasma concentrations. NTproBNP is approximately 6 times higher in levels than BNP. BNP and NTproBNP levels rise with increasing age, so the NTproBNP used for ruling in acute decompensated heart failure has different cutoffs by age group. In patients, NT-proBNP less than 300 excludes acute decompensated heart failure, while NT-proBNP for ruling in acute decompensated heart failure is 450 or more for adults less than 50 years old, more than 900 for 50 to 70 years old, and more than 1800 for more than 75 years old. In outpatients, an NT-proBNP less than 125 makes acute decompensated heart failure unlikely. This is in contrast to the 300 cutoff used for inpatient. And an NT-proBNP more than 600 in the outpatient setting makes acute decompensated heart failure likely. This is in contrast to the 3 age groups we use for inpatient, 450, 900, and 1800 as the cutoffs for ruling in ADHF in less than 50 years old, 50, 75 years old, and more than 75-year-olds in the inpatient setting. Things that decrease BNP and NT-proBNP, again, that increase are advanced age, renal dysfunction, acute coronary syndrome, pulmonary disease such as cor pulmonale or ARDS, PE, AFib, aflutter, high output states such as hyperthyroidism and sepsis, valvular heart disease, and anemia. Things that decrease BNP and NT-proBNP are obesity, cardiac tamponade, pericardial constriction, and flash pulmonary edema. In obesity, androgens from adipose tissue suppress release of BNP, so in BMI more than 30, slash the above cut points by approximately 50%. For example, you should have the BNP cut point from 100 to 50 pg per milliliter for ruling out acute decompensated heart failure. HFpEF patients naturally have lower concentrations of BNP and NTproBNP than HFrEF. ProBNP and BNP in risk stratification of chronic heart failure now has a class 1 recommendation. Each 100 pg per ml increase in BNP has a 35% increase in relative risk of death. For NTproBNP, the risk increases exponentially above 1000 pg per ml. So it is okay to check BNP or NTproBNP periodically in clinic several times a year. It is also okay to check BNP and NTproBNP prior to inpatient discharge because of studies that showed that bringing down the BNP by 50% pre-discharge was associated with improved mortality. What do the 2022 heart failure guidelines say about this? In patients presenting with dyspnea, measurement of B-type natriuretic peptide, BNP, or N-terminal prohormone of BNP is useful to support a diagnosis or exclusion of heart failure. That's a class 1 recommendation. In patients with chronic heart failure, measurements of BNP or NT-proBNP levels are recommended for risk stratification, class 1. In patients hospitalized for heart failure, measurement of BNP or NT-proBNP levels at admission is recommended to establish prognosis, class 1. In patients at risk of developing heart failure, BNP or NT-proBNP focused screening followed by team-based care including a cardiovascular specialist can be useful to prevent the development of LV dysfunction or new onset heart failure, class 2A. In patients hospitalized for heart failure, a pre-discharge BNP or NT-proBNP level can be useful to inform the trajectory of the patients and establish a post-discharge prognosis, class 2A. Now let's touch upon other labs and biomarkers. In CHF decompensation patients, the best predictor for in-hospital mortality is a high admission BUN. The next best predictor is a low admission systolic blood pressure, less than 115. In CHF exacerbation, elevated levels of galectin-3 is associated with increased heart failure readmission rates, arrhythmias, and mortality. Galectin-3 is also associated with the development of PAH. ACE inhibitors increase levels of substance P by inhibiting their degradation, whereas ARBs have no effect on substance P. 25% of patients with acute decompensated heart failure will have hyponatremia, and this may occur from sodium restriction, intensive diuretic therapy, a decrease in the ability to excrete water due to reductions in renal blood flow and GFR, and a rise in circulating vasopressin. Vasopressin, or antidiuretic hormone, causes vasoconstriction by binding onto V1 receptors on vascular smooth muscle and causes free water retention via binding onto V2 receptors on the renal collecting duct. Vasopressin levels are elevated in both acute and chronic heart failure and contribute to hyponatremia, an adverse prognostic marker. Was previously popular due to its ability to improve pulmonary capillary wedge pressure and normalize serum sodium concentrations. However, the Everest trial failed to show a reduction in mortality or heart failure hospitalization using tolvaptan, so it is less popular now. That's all for biomarkers and lab abnormalities in heart failure.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.